Good morning. I'm Pat Walker from Walter Reed. Thank you for the opportunity to present our findings, which I think should dovetail nicely with the last presentation. We have nothing to disclose. Over the past several years, the initial studies of TXA in trauma have demonstrated a mortality benefit with TXA administration without an apparent increase in thrombotic complications. So the CRASH-2 study was an RCT that looked at civilian trauma, and they described an improvement in all-cause mortality if TXA was given within the first 3 hours of injury. Similarly, the MATTERS study in combat trauma also demonstrated a mortality benefit with TXA. More recently, however, there's been some data that suggests there is an increase in VTE as an independent risk factor associated with TXA administration. Currently, the TC3 guidelines recommend TXA administration if a casualty is anticipated to need significant blood transfusion and can be given within 3 hours of the point of injury. With regard to TXA and traumatic brain injury, there's a theoretical advantage that the anti-fibrinolytic properties of TXA can counteract the release of tissue factor and other mediators that can lead to a coagulopathy with traumatic brain injury, and that can lead to a potential decrease in the progression of intracranial hemorrhage. Within the CRASH-2 study, there was a nested portion of 270 patients who had intracranial hemorrhage and were given TXA, and the authors there noted there was no difference that they could measure in ICH progression, but they did show that TXA was safe in those traumatic brain injury patients. Currently, the CRASH-3 trial has been proposed and is enrolling 10,000 patients to look at TXA administration specifically in TBI patients with intracranial hemorrhage. And thus, as we've talked about, we often see military patients with severe TBI that are located in austere settings without immediate access to neurosurgery and in whom TXA might be an effective adjunctive therapy. And so in this study, we sought to look at patients who had combat-related intracranial hemorrhage and determine if there was an association of TXA with neurologic outcomes, any difference in the progression of intracranial hemorrhage, as well as the incidence of VTE. We hypothesized that we would not see a difference in neurologic outcomes or progression of intracranial hemorrhage, but that we would see an increase in VTE. So we performed a retrospective analysis of 687 casualties that came to Walter Reed from October 2010 to December 2015. These were all United States service members that survived transport back to the continental United States. We collected demographics, types of injuries, as well as their GCS and Glasgow outcome scores as outcomes measures. And you see there the Glasgow outcome scores, which measures functional outcomes 6 months after injuries. We also looked at their initial and interval CT scan results, and the interval CT scans generally were obtained within 24 to 48 hours after the initial CT scan. Progression of ICH we looked at as a qualitative measure based on radiologist interpretation. We performed univariate analysis stratified based on TXA administration, progression of intracranial hemorrhage, as well as incidence of VTE, and then we also made a logistic regression to look for independent risk factors for VTE. So of the roughly 690 casualties that we reviewed, 71 had intracranial hemorrhage. Of these, 14, or about 20%, received TXA. As we would expect, those that received TXA were more severely injured. 80% of them were injured in an explosive blast. 18% were injured from a gunshot wound, and we had one closed head injury related to a helicopter crash. There was not a difference in massive transfusion, defined as administration of 10 units of packed red blood cells or fresh whole blood within the first 24 hours between those that did and did not get TXA. We saw that those who got TXA were more likely to be coagulopathic, as defined by an INR of greater than 1.5. We did not have any viscoelastic data to this point in the DoD registry, so we just looked at INR. Patients that got TXA also had a higher incidence of lower extremity amputation, and as we would expect with that, a higher incidence of a severe injury by extremity AIS. There was not a difference in chest or abdomen AIS in TXA administration, and actually of the 14 patients who got TXA, there were 4 that just had isolated severe head injuries without a significant truncal or extremity injury. Regarding the traumatic brain injuries, patients that got TXA were more likely to have a lower GCS, as noted in the field. Half of patients had a penetrating traumatic brain injury, and there was no difference in who got TXA in that group. And then most patients had a variety of different types of intracranial hemorrhage, the most common being intraparenchymal, followed by subarachnoid, subdural, interventricular, and epidural hemorrhage, and there was no difference in those groups in terms of who got TXA, as well as those who had diffuse axonal injury. For our neurologic and mortality outcomes, we saw no difference in who required cranial decompression based on TXA administration. There was no difference in discharge GCS, but we did see a statistically significant increase in improvement in GCS in the group that got TXA. There were no differences in Glasgow outcome scores or mortality. So we did our analysis of the progression of ICH. We excluded 26 patients who got cranial decompression prior to their interval CT scans. So these are just 2 patients that got TXA and then had a initial and interval CT scan to compare. And within this group, TXA was not associated with a decrease in ICH progression. And as a matter of fact, there was a trend of a p-value 0.09 towards an increase in ICH progression in this group. We think this was in large part to the fact that these patients were more likely to be coagulopathic, but an interesting trend. When we looked at VTE, the incidence in this group was about 12%, 9 out of 71. ISS, as we would expect, was associated with VTE, as was lower extremity fracture, pelvic fracture, ventilator days, and blood products transfused. TXA, additionally, was on univariate analysis statistically significant for an increase in VTE. When we used all these variables in a logistic regression model, however, we found that there were no independent risk factors for VTE. So in summary, there was no difference in the progression of intracranial hemorrhage, the need for cranial decompression, Glasgow outcome score, or mortality with TXA administration. And in fact, we saw a trend towards increased progression of ICH with TXA, and we believe that's because we saw more patients who were coagulopathic in that group. There was an increase in GCS improvement with TXA, but that should be considered in the context that these patients had a higher, were more severely injured and had a lower GCS in the field, as the discharge GCS was the same between the 2 groups. Again, we saw an increase in VTE on univariate analysis with TXA, and we believe that a paucity of data contributed to the lack of significance on multivariate analysis. So in summary, we believe that TXA administration in military patients with TBI, that decision should take into account the availability of neurosurgery as well as the severity of extracranial injuries, knowing that there is likely an increased risk of VTE with TXA administration with a potentially questionable benefit with regard to the traumatic brain injury. That concludes our presentation. Thank you very much. I'll take any questions.